SARS-CoV-2 infection, an update on the laboratory diagnosis of COVID-19. My name is Esther Chernak. I'm an associate professor at the Drexel University Dornsife School of Public Health and at the Drexel University College of Medicine. I'm also the director of the Center for Public Health Readiness and Communication at Drexel University, and I will be the moderator for today's session. We're fortunate today to host two highly acclaimed experts in the field of clinical laboratory diagnostics as well as clinical infectious diseases, two really perfect guests to help us navigate through and understand the rapidly changing field of SARS-CoV-2 diagnostics. I will introduce each of them, and then each will give a brief overview of a topic within this area, and then we'll open it up for questions and answers. So our first guest is Dr. Alan Evangelista. Dr. Evangelista is the Director of Microbiology, Virology, and Molecular Diagnostics in the Department of Pathology and Laboratory Medicine at St. Christopher's Hospital for Children in Philadelphia, Pennsylvania. He's held this position since arriving in August 2009. He's a clinical professor in the Department of Pathology and Laboratory Medicine and also in the Department of Pediatrics at the Drexel University College of Medicine in Philadelphia. He received his doctorate in microbiology from Rutgers, New Jersey Medical School in Newark, New Jersey, completed a postdoc fellowship in medical and public health microbiology at Temple University School of Medicine in Philadelphia. Prior to joining St. Christopher's Hospital, Dr. Evangelista was the Director of Microbiology at Ortho McNeil Janssen Pharmaceuticals, a division of Johnson & Johnson in Raritan, New Jersey. And prior to joining Johnson & Johnson, he was the Regional Director for Clinical Microbiology at the Medical College of Pennsylvania and Hahnemann University Hospital System in Philadelphia, Pennsylvania. He is a diplomat of the American Board of Microbiology, Medical Microbiology, and he's published numerous abstracts, papers, and book chapters on topics related to infectious diseases, molecular diagnostics, and antimicrobial resistance. He has co-chaired the annual symposium of the Eastern Pennsylvania branch of the American Society of Microbiology for the past 10 years. Dr. Debra Powell is the Chief of the Division of Infectious Diseases and the Medical Director for Infection Prevention for Tower Health Reading Hospital. She obtained her undergraduate degree at Penn State in microbiology and then worked for 17 years in the microbiology laboratory. She then completed a Master of Science degree at Medical College of Pennsylvania in Hahnemann under the supervision of Alan Evangelista, and then completed her medical degree at Penn State Hershey College of Medicine. She completed a residency in internal medicine at Reading Hospital and a fellowship in infectious diseases at Penn State Hershey College of Medicine, and returned to Reading Hospital in 2008, where she is the chief of the infectious disease division since 2014, and she is also the medical director for infection prevention. So you can see we have two really highly qualified guests to help us navigate through the changing landscape of COVID diagnostics. We'll begin with Dr. Alan Evangelista, who will give us an overview of the available diagnostic tests for SARS coronavirus 2. So I will share.
Thank you very much, Esther. That's really a very nice introduction. If we could put that, there we go. And so we're going to talk about some of the laboratory diagnostic tests this afternoon. And what I'd like to do on the next slide is go over, well, the next slide just shows that I don't have any conflict of interest. And the next slide is sort of some of the objectives that we're going to take a look at today. We're going to look at the principles of PCR, polymerase chain reaction. We're going to look at some of the limitations of some of the testing and look at the definitions of sensitivity, specificity as it applies to these tests. And more importantly, looking at some of the specificity and some of the predictive values for the serology tests. Also, there's a number of assays that we're going to look at in addition to PCR, which are the rapid nucleic acid tests, and there is one antigen test. Today I'm going to focus mainly on just the tests that are EUA approved by the FDA. The FDA is currently looking at 400 tests, and fortunately I'm not going to talk about 400 tests today. I'll just go over the few. I think there's another, yeah, there's one more over here. And we'll also look at the antibody tests, specifically IgG, because those are the ones that are currently available, but there is one test that does total antibody, currently EUA approved as well. Okay, the next slide gives us some of the requirements for PCR. And actually there's three basic steps. There's extraction, amplification, and detection. There's a lot of different ways that you can extract a sample. Typically it's some type of a protease. Sometimes there's beads, sometimes there isn't. Amplification is interesting because you have to, there are certain parameters to look for. First, identifying a target. What target are we looking for? Especially if it's an RNA virus, it's going to be a certain number of base pairs, anywhere from 100 to 10,000. If it is an RNA virus, then we have to do a reverse transcriptase step first to make a copy or complementary DNA. Then we have primers that initially attach to the regions of the target. We have the ATCG bases. There's always an internal control to make sure the PCR reaction works properly. And there's a heat-stable polymerase enzyme, an analyzer or a thermocycler that goes through the reaction. And then there's some kind of detection method. Usually it's a probe with a fluorescent dye attached to it. Next slide shows the reverse transcriptase step. So we're starting with an RNA target. On the left side of this slide is a representative of the coronavirus. And all the coronaviruses look the same as far as the external features. And there's going to be minor details in some of the genome of them. But we start out with an RNA target. We make a copy using an RNA-dependent DNA polymerase. And basically, the difference between RNA and DNA is you have uracil with RNA and thymidine with DNA. So we make that copy. We remove with RNase H, we remove a single strand of RNA, put on the second primer, and then we have a DNA template. Once you have a DNA,
Alan, you just muted yourself.
okay. Now, can you hear me?
Go ahead.
Okay, good. So these are the 3 steps for thermal cycling. And it's remarkable, and over the last 10 to 15 years, this has become a lot faster. It used to take a few days to do PCR, at least an overnight reaction. Now we can denature our double strand in 10 seconds. We anneal what the primer's attaching in about 20 seconds. And then we can allow the extension to occur over a minute, sometimes shorter. The next slide will show us an example of a typical reaction if everything works properly. So if you have all the bases and you have enough of the master mix, you start off with a target. After 35 cycles, you end up with 68 billion copies. And that's assuming that it works right. Most of the systems are set up to do at least 40 cycles. And then at the end, this is a probe that as the extension occurs, the probe breaks and you have a reporter marker, which is fluorescence, and then you can detect fluorescence as the reaction occurs. The next slide shows the different cycle thresholds. So there's a really good association between, if your cycle threshold shows fluorescence early on, you have quite a bit of product present. So that's how we can tell roughly viral load. So the red line on the left is a large amount of virus. It only took 8 cycles or 9 cycles for it to be detected. And on the far right, the purple line shows a lower viral load, the purple cycle showing that it's taking several more cycles to occur. It's interesting that around the cycle 25 is where we see the average detection for a lot of the symptomatic patients. This is an interesting paper by He that talked about the temporal viral shedding. So on the top left is SARS from 2013, shows that a typical virus, you'll have symptoms, which is the line on the left, and then you have the blue curve, which is viral shedding. These are infectious virus particles, so it's identified by viral culture. And on the bottom is the seasonal influenza, where you have some viral shedding prior to the onset of symptoms. On the right side is SARS-CoV. This shows viral culture. So 2 interesting things here is that you start to see a peak in virus 2 days before symptoms occur. So that's a problem. And this is assuming that somebody is obviously going to be symptomatic. So the pre-symptomatic syndrome could be 2 days. It could even be earlier than that. And you'll see some of the data that I'll show you. It may even be 3 to 4 days before symptoms. It tails off then. And as soon as you have symptoms, typically infectious particles will go below detection and the culture will become negative by day 8 or 9. PCR, on the other hand, may stay positive for 14 days typically. And in some patients, you might have residual RNA up to 21 days. Now, the next slide is a recent paper in the New England Journal showing different populations. This is all taken from nursing home residents, but you see on the top line the typical symptoms, and you'll see that the distribution of where the culture is positive. It's usually at a fairly low cycle threshold. There's a lot of virus present. In order to have a viral culture even be positive, you have to have at least 1 million copies of virus per ml. So once you get below 10 to the 6th, it's going to be very unlikely that you're even going to be able to get a culture positive, although that's where the value of the PCR tests are concerned. And then you'll see that the median here is around 25 as far as looking at this pre-symptomatic stage. Now, if we look at the bottom, these are the asymptomatic patients. So there's only a few in this particular study, but it shows us that they're going to be detectable at a fairly the same median viral load as we see for symptomatic patients. So we're not seeing them at the very low end. So asymptomatic patients tend to not have extremely high virus, but they have enough virus that you can't really distinguish symptomatic from asymptomatic based upon a PCR test. And with more numbers, this is at N of 3, so it's a very short study, but it's very difficult to do this type of study. The next slide also is that same study, and it shows distribution and the temporal distribution. So on that first graph that I showed you, this is 0, so this is where we start to see the onset of symptoms, and you can have positive viral cultures all the way up to a week before, 6 days before the onset of symptoms. The other 2 points that I wanted to mention here is this is actually a fairly low cutoff value. So the cutoff value is at the top of the graph here, 20, from 10 to 20, that's a lot of viral load there. And we're detecting that type of a CT or a cycle threshold on day 13 after the onset of symptoms. And this is where viral cultures end on day 8 or 9. We're not going to see a positive. So presumably the patients are no longer infectious after day 9, but they may have a residual PCR detection beyond that. So it shows that this is sort of the window of opportunity that we have. We have a little bit of time when you're testing somebody asymptomatically, say they want to go back to work and you want to see if they have an acute infection, whether they're symptomatic or not. Most likely they're not going to be symptomatic. No fever, no shortness of breath, no cough, just to see, does this patient currently have an asymptomatic infection? Best way to do it is PCR. There is a limitation. You only have that 14-day window, or maybe a 2 to 3 week window at most, depending on the individual, where that test is going to be positive. The next slide gives us a definition of sensitivity. So this is assuming that we have roughly a 90% sensitivity, which is not a very good test, but 10% of the people that have the disease will go undetected. So we have 10% false negatives here. And we're also looking, when we're analyzing these PCR tests, we're looking at the limit of detection. So how low can you go as far as copies per ml? And the next slide will have the bottom of this particular slide, specificity, one more. The specificity is the ability to correctly identify patients that do not have disease. So in this case, a 90% specificity would not be good either, because you're going to end up with 10% false positives here. You're going to be missing 10% of the patients that are, you're not missing them, but your patients without disease, you're incorrectly identifying them as positive. And that's a problem as far as antibody testing is concerned, because you don't want to give the person the false sense, the false feeling that, oh, you have immunity, we're detecting antibody, and truly you're detecting antibody to something else. And we're seeing, and we'll talk about it later, but autoimmune disease is responsible for a lot of these false positives. The next slide gives you an example. We have to think about disease prevalence also. And currently, as we get more and more antibody testing, we're going to be able to determine whether disease prevalence is 1 or 2% or up to 5%. 5% is being very generous, because we don't believe that disease prevalence is that high. But as far as the, if you have a negative predictive value of 99.7%, that's pretty good as far as the reflection of sensitivity. You have a false negative rate of 0.3. But if the positive, with a specificity of 95% and a prevalence of 5%, your positive predictive value may be 50%. So that means half of your results are going to be false positive. So that's where the specificity really plays a big role. And on the bottom half of the slide, it talks about a specificity of 99%, and therefore you're going to reduce your false positive rate down to 16%. So it's not just how sensitive and how specific a test is how much of the population is infected. If you do a test in New York City, you're going to have fairly high sensitivity specificity. If you go out to Montana, where the prevalence is going to be 0.1% maybe, or 2 or 1%, it's going to be a lot different. All right, the next slide, we keep that in mind. We get a lot of questions about the type of specimen, and typically a nasopharyngeal specimen has always been historically the best specimen for viral, especially if you use a flock swab. And flock swabs now are hard to come by, but they're a soft nylon. When you sample the nasopharyngeal cavity, you pull out a lot of material. As soon as it goes into viral transport, it elutes out completely. And if you do the same thing in a nasal swab, but a mid-turbinate, so halfway up the nose, you're getting a very high sensitivity. And quite frankly, I don't think there's much of a difference between nasopharyngeal and nasal for mid-turbinate. And there's an advantage of mid-turbinate because now you can use either a foam swab. Synthetic swabs are a little bit not as good, but they're pretty good. There's a lot of talk about using saliva, and this is data from the IDSA guidelines that were recently published. That's down, sensitivity goes down to 85%. A nasal swab, just sticking it in the nose in the anterior nares, is down to 76. And a throat swab is not very good at all. That's a synthetic swab, and that gives only about 56%. It's interesting because a lot of the studies coming out of China, especially in the earlier part of this year, were on throat swabs. That's the primary mechanism of sampling, and it was not a very sensitive test. So in the news, you're hearing about, well, maybe the number of cases in China was a lot higher, probably if they were using predominantly nasopharyngeal swabs instead of throat swabs. The numbers may have been a little higher there as well. So the next slide gives us some of the PCR targets. Now, some of the PCR reactions, the entire genome of CoV-2 is about 29,000 base pairs. And we're looking at the open reading frame 1A and 1B. That's on the left side of the slide. So you're going to see some of the assays with targets in those regions. To the right side, in the green bars there, you see the spike proteins. That's another very good target. And so is envelope and membrane and nucleocapsid. So those are where the position on the genome of where those particular targets may be. As you remember, when you're designing a PCR test, it's either 10 to 100 base pairs within those regions. The next slide gives us a look at some of the classic methods that are used now. And these are the 96-well high throughput tests. They're not necessarily quick tests. They're usually anywhere from 3 to 5 hours to complete. And that 3 to 5 hours encompasses the extraction step, which is often an hour and a half to 2 hours. The amplification step, which may be another 2 to 3 hours on top of that. So that's why the overall timing. CDC test, which was the classic test, they were using the ABI 7500 analyzer. And it just shows the different targets. So they're using the N1, N2 targets there. Copies per ml varies depending upon who's doing the study. It's nice to have a standardized calibrator and then dilute that to know how many copies, viral copies per ml you have. Unfortunately, these are taken from different publications, so it may jump around. But the classic PCR tests, the larger throughput, usually have between 150 to 250 copies per ml. And as you go down the list, you see that the Roche assay uses the open reading frame 1A and B and the envelope. Abbott has a test that uses the different combinations. Thermo Fisher markets the Applied Biologics, the ABI test. LabCorp uses ABI and so does Quest, but different analyzers, and each group uses a different extraction method also. So you may mix and match different methods, but the nucleoproteins, especially N1 and N2, are fairly common in some of these assays. The next slide, continuing on the PCR theme, these are additional tests, but not using the 96-well format. And they're a lot faster as well. So the Cephia test, which is very popular, unfortunately, there's allocations, as are with most of these assays. So none of the companies can produce the number of kits that hospitals and laboratories would like to purchase. But it's a 45-minute assay. It's very accurate, down to 200 copies per ml. It uses an N2 target as well as an envelope target. And if either of these are positive, the test is positive. Diasorin Molecular has a very accurate assay too. And one of the studies, one of the references, it was down to 40 copies per ml. Other references show is up to 150 to 200, but it's on a different format. It's instead of a cartridge, it's a disc, and you could put up to eight tests on a disc. And the targets are the spike glycoprotein and the open reading frame 1AB. GenMark has an assay, and the comparative studies have showed that the limit of detection is a little bit higher here. It's about 1,000 copies per ml, and it's about a little bit longer, about a 3 to 4 hour assay. BioFire had a single-use assay, which was used by the Department of Defense, and now they are coming out with a respiratory panel that includes CoV-2. They use an S and a membrane marker, and they're down to 160 copies per ml. It's a 45-minute assay. And Luminex had a single cassette, but you can put 6 to 12 of these cassettes into the instrument at a time. And it's a nucleocapsid and an open reading frame. But the limit of detection is a lot higher. It's about 75,000 copies per ml. The next slide goes on with some of these other assays. There's so many PCR assays that I couldn't possibly capture them all. So I was going with some of the more common ones that hospitals might use. BD Max and the Hologic Panther have assays, and they're both in either the 200 or the anywhere from 83 up to 625, depending upon the investigator and how they did their comparative testing. I'm gonna move this just a little bit because, okay, that's better. So the next slide goes over some of the other assays. Now this is where we fall down a little bit. We're anxious to get point of care testing. It's very important, but there's a compromise. If you with some of the isothermal assays, the Abbott ID Now test got a lot of publicity when it first came out. It's an okay test. It's not a very, very good test. There was a new article that came out from New York, and that's the reference at the bottom here that was just posted a few days ago, that showing that the limit of detection is up to 20,000 copies. And then instead of doing a PCR reaction, it's a template just expanding the RNA dependent RNA polymerase. It should be RDRP. And it's a 15-minute assay, so that's the good news. If you use a direct swab into the sample extract, it's a lot more sensitive than if you put this swab into a viral transport medium, because there's a dilution effect and it'll reduce the sensitivity. You may get up to 30% false negatives there. So it depends upon how the swab is brought to the laboratory. And thinking about it, the study in New York took a dry swab and put it into a sterile tube and put a screw cap on it instead of putting it into an envelope that it came in. So what you're trying to do is minimize the drying out as quickly as possible. So there may have been an artifact in that study. And then there's only one antigen test currently that's received FDA emergency use authorization, and that's the Quidel Sofia. That has a little bit higher detection level of 850, but the sensitivity is only 80%. The actual package insert says to do a molecular test if it's negative. So it's not a very comforting assay to say if you have a negative test, you may still be positive because it may miss up to 20%. So the recommendation is that if someone has symptoms and they're in a potential acute infection, then this test will work fairly well doing it. And that's probably be true for most antigen assays. You have to have a lot of virus for an antigen assay to be positive versus something that's a molecular method. The next slide gives us a little bit of a picture of the antibody assays. There's a lot of antibody assays now as of last week and the week before. These are just a few of them. A lot of the ones that are on these mainstream instruments are chemiluminescent, so they have a fairly good detection. And the Diasorin IgG is an S1, S2 targets with pretty good sensitivity, specificity. The specificity we'd like to see above 99%, because if it goes below 99%, then the false positives are going to creep in. And if somebody has rheumatoid factor or some other autoimmune disease, they may come up with a false positive. The other thing that we look at is there a cross reaction with human coronaviruses in this particular column here, on the second to the right column, and then what is the predictive, the positive predictive value at a 5% prevalence rate. So the predictive value, if it's a positive, is 88%. The Abbott Architect assay is very sensitive and specific, although they do have the caveat that in their package insert or their instructions for use, it does say that they cross-react with human coronavirus antibody. So, but in spite of that, the positive predictive value is pretty good. Then there's a Euroimmune assay, which can either be a manual 96-well assay or it can be put on an automated analyzer. This goes after the S1 as well. Sensitivity here is only 90%, but specificity is above 99%. So, and they do not cross-react with a human coronavirus. And then there's an OrthoVitros, that's another chemiluminescent assay with a slightly lower sensitivity. Specificity is the 99.1, so we're looking at that 88% positive prevalence again. And I can't see the assay times are blocked for me. Let's see if I can move this over here. Oh, here we go. Okay, so most of these, the first two assays were 30-minute assays. The Euroimmune is more manual. If you're using it manually, it's going to be about a 2 to 3 hours long incubation steps there. And the OrthoVitros is 1 hour. There are other assays, a lot of other manufacturers that have automated systems, or the assays are available from some of those as well. The website on the bottom gives you the most up-to-date EUA-approved devices. The next slide gives us a look at a sort of a summary of some of these diagnostic tests. So if somebody's presenting with an acute infection, you're looking at the RT-PCR test as your gold standard. The nucleic acid amplification tests that look at isothermal amplification, a little bit less sensitive, and the one that we have to go on now is the Abbott ID Now test. Then if you're looking at antibody, there is a role for IgM and IgA tests. So there is going to be a second generation of tests coming out. After the IgGs were first released, a lot of the manufacturers now are either going to do an IgM by itself or an IgM IgA. The reason for this is that you produce antibodies pretty quickly. IgM, you start producing antibodies day 1 after symptoms. And so from day 1 to day 7, about 85% of the patients are going to be positive in that short period of time. And IgM is very useful for patients that may have a negative molecular test. Not all tests are 100%. So occasionally someone may have a molecular test where you suspect COVID-19. Chest x-ray, CT scan looks like COVID, but the molecular test for whatever reason isn't coming up positive. It may be helpful then to do an IgM. IgM is a big molecule. It's intravascular. It stays in the vasculature. It doesn't get out into the mucous membrane, so it's not a very good neutralizing antibody because the virus is on receptors in the nasopharynx, in the throat, in the lungs. IgM is staying inside the bloodstream. It's a good marker for acute infection. IgA, on the other hand, also appears early. And so I know that Diasorin is going up, is going to be releasing an IgM-IgA combination also. It's very abundant on mucosal surfaces, and it does have neutralizing activity. So a combination of those two may give you, analytes may give you an early indication. IgG is sort of the go-to as far as recent or remote past infection. So this starts to appear 6 to 14 days after symptom onset. So about 90% of the patients are going to be positive as soon as within 14 days after symptom onset. So that's a really good screening. And it does have viral neutralizing activity. It remains to be seen which ones are going to be more neutralizing antibodies than others, because IgG by itself may be against the spike, may be against the nucleocapsid, may be against the envelope, and the data is still out as far as which ones are going to be most effective. But probably the spike protein, if you can block that, you're blocking attachment, and that makes sense from a theoretical point of view. IgG is around for a long time too. Once you produce IgG, at least 6 months to a year with other coronaviruses. We don't know how long it'll be around for SARS-CoV-2, but we would think it would act a lot like other coronaviruses. And I mentioned before, the autoantibodies in particular may have a false positive. Patients that are taking a lot of biotin also, because all the chemiluminescent assays use a streptavidin biotin or a biotinylated conjugate. And so if somebody's taking high dose vitamins and they have lots of biotin, they may potentially produce a false positive, but usually it's due to autoantibodies. And the next slide, which I believe is the last slide, is sort of an overview. How do we use these tests as far as the IgG test? Well, if somebody is recovered from COVID, certainly that plasma is going to be very useful. And so we can screen patients if they have a very high titer, like a 1 to 160 titer. That fits the criteria for donor plasma. When we do seroprevalence studies, how are we going to know who in the community has been infected? Because 50% of people are asymptomatic, another 30% have mild infection. So screening healthcare workers for their immune status, allow them to go back to the front line and take care of patients. So this has a lot to do with patient exposure. And then who's going back to work? At least if you're going back to work, you should know your immune status. Have you been exposed? Haven't you been exposed? And a lot of times we have to screen with both a PCR and an antibody test to see if you have a current acute disease, especially if you're asymptomatic or antibody. And then as we move forward with vaccine candidates, pre-screening individuals are going to be very important for vaccine trials, and looking at the timing of the immune response and looking at these serologic assays to see which ones actually detect neutralizing antibody and how long is that going to be produced. So as we move into the future, these assays are going to be very valuable as well. I believe that's the last slide. So I'll stop there and give Dr. Powell a chance to present some information.
Thank you very much for that terrific introduction. A lot of great information. I'm going to hand it over now to Dr. Powell to give us an overview of how the clinical environment, how these tests are used in the clinical environment. So take it away, Dr. Powell.
Yeah, thank you very much for letting me participate in this discussion. And thank you, Alan, for that great presentation on all the different tests. So I'm going to go initially through the data, both global, US, and local data, in addition to who to test based on what symptoms, and also the IDSA guidelines on who should be tested. And also, I have no disclosures or any conflict of interest. So this is from the Johns Hopkins website last night. So this was all current as of last night, but realized that, actually yesterday afternoon, that this is changing very rapidly. So we've had 4.7 million cases across the globe and over 300,000 deaths globally. Next slide. And in the US, we've had 1.4 million cases with over 89,000 deaths for a mortality rate of approximately 6%. I presented 5 grand rounds over the last 2 months to the Department of Medicine and globally across Tower Health. And I kind of showed them some of that data this morning. And back very early on, about 2 weeks into this outbreak, we had like 1,600 cases in the US. And now we're up to 1.4 million cases within that 2-month period of time. It's absolutely amazing to me how this has evolved over time. And then the bottom map of the US shows you the high density states with the darker purple color having the most cases, and we in Pennsylvania are right up there. Next slide, please. And this is our Pennsylvania totals as of last evening. Again, total cases over 63,000 with 4,500 deaths. We have a positive rate of approximately 19% of those that are tested that have symptoms, and a 6.7% mortality. And this also shows you within Pennsylvania where the highest density is, which is in southeastern Pennsylvania. Next slide. The state of Pennsylvania also breaks this down based on age and on hospitalization. So the predominant people who are testing positive right now are between 25 and 49 years of age. And then also decreasing in the upper age groups. And then the hospitalization rates are mostly over age of 65. And we're seeing that currently in-house also. At least 20% for those over 65 to 79 years of age. Thank you. Next slide. And this is off the CDC's website from last evening, showing you can break this down for state and then kind of risk stratify it by county. So Philadelphia has the most cases, and then they also give you the number of cases per 100,000 of well over 1,000 with over 1,000 total deaths. I'm in Berks County, so you can see we're number 5 in this list with 873 per 100,000 with 208 deaths to date. If you'll advance, please. And what I like about this is my county. So this is Berks County, and the state of Pennsylvania actually can break this down on a very granular level down to zip code. So we can see where our hotspots are in our county. So this is actually in the city of Reading, and where we've had 677 cases in that zip code and 890 that are negative. So you can kind of see where your primary incidence is here in the area. Next slide. So you can do that for any county you want to take a look at. So all your viewers can go back and look at the state and go down to that granular level, look at their county and where their hotspots are. This is the epidemiologic curve presented by the Pennsylvania Department of Health, showing the southeastern area of our state is where the predominant number of the cases are, and how this has kind of plateaued and has started to decline. The plateau kind of started the week of April the 5th and then went out to about the 19th, but we are seeing decreasing numbers overall. Next slide. So what we do at Tower Health is every day we actually accumulate all our data for our health system. So we look at the number of people who've been tested to date. So we've tested over 11,000 people with over 3,000 positives. We take a look at how many ICU beds we have, how many ventilators are in use, occupancy across the health system to see where we're running out of beds. We never came to the point that we were running out of ventilators, and we've always had a decent number of ICU capacity. On this table here down the very bottom shows you our occupancy rate for our ICU. Currently it's 44%, med-surg is 60%, and our IMU, which is the intermediate care unit, kind of like a step down from an ICU, is 63%. And we're only using 22% of our ventilators. So overall Pennsylvania, we kind of dodged a bullet here. So we've actually been able to kind of respond to this outbreak quite well. Next slide. And then we break this down per hospital. So every hospital reports up to the Tower Health overseeing body. And the Tower Health huddle occurs every day at 10 o'clock for the whole system, but every hospital reports out before that. So for Reading Hospital, we have the chairs meet at 8 o'clock. It goes to the system level at 9 o'clock. And then by the 10 o'clock, we have the whole Tower Health-wide data. So this is the data for Reading Hospital yesterday. Again, we have 10 people in our ICU that are positive, 72 people that are confirmed positive out in other areas of the hospital, and 24 with pending results. And this is my challenge, honestly, is all those pending results and not having a decent number of immediate access to testing to determine if those patients are really positive or not. Next slide. And this data here is actually publicly reported. So what we have are links out through our health system to show you for every hospital in the system how many tests have been completed to date and how many have been positive. And then the next slide shows you for Reading Hospital the number of inpatients we currently have, which was 83 as of yesterday, and how many deaths we've had so far to date for that hospital. So all this is publicly reported so people can take a look at this. Next slide. So who should we test? So this was a study published in New England Journal back at the end of April, looking at over 1,000 people that were COVID positive in 552 hospitals in China through the end of January. Their composite endpoints were admission to an ICU, use of mechanical ventilation, or death. And the most common symptoms they saw were fever and cough, and diarrhea was uncommon. The median incubation time was 4 days, and the most common radiologic finding was a ground glass opacity and low over 50%. And also lymphocytopenia, which is a low lymphocyte count, was present in 83% of the patients on admission. So it gives you an idea what composite symptoms we're looking for in that population. Next slide. I get asked fairly frequently about GI symptoms in this population. And overall, you can see the very bottom, between 1 and 5% in most studies were reported, up to 10% in this one study that was published by C and Lancet. But basically, it's not really a GI disease. It's more of a respiratory disease. Next slide. So just to go over the IDSA guidelines for testing, these were updated at the beginning of the month, and Alan kind of talked a little bit about these. And the IDSA is the Infectious Disease Society of America, and it's the oversight body for infectious diseases. And they look at the study design, if they're randomized or observational. And again, they kind of look at bias and any confidence they have in the test results that came out of that study. Next slide. And they gave 15 recommendations, and I won't go into full detail on these, but just to let you know kind of what the overlying endpoint is. So they recommend testing people who are symptomatic, even if the clinical suspicion is low, and they gave a strong recommendation for this. So basically, if you have symptoms, we want to have you tested with a COVID PCR-based test. Next slide. And the symptoms that they're recommending are cough and shortness of breath, and at least 2 of the following symptoms. So usually these patients have fever and possibly sore throat. The loss of taste or smell is interesting, and we had a neurocritical care doc on the town hall yesterday kind of discussing this. It's kind of unusual, so it's interesting, and it usually does resolve, but just as of interest. Next slide. And then what Alan went through is it gave recommendations based on the type of specimen to obtain. So if you'll give me the next slide, I'll kind of show you some of the data. And Alan gave you the overview regarding that already. So the nasopharyngeal specimen, again, has a really high sensitivity and specificity. So that's a great specimen to collect. The nasal swab, again, 95 and 100. But the oral and the nasal kind of drop off in the saliva, much like Alan already mentioned. And then they gave some more statistical analysis based on the pretest probability and overall the accuracy of some of these tests. Next slide, please. Again, swab collection by patients or healthcare providers. And I'll go to the next slide because it kind of illustrates this better. So in this comparison, they found that actually self-collected nasal and healthcare collected specimens actually had pretty good sensitivity and specificity in this one particular trial, looking at, so you can do a drive-through testing and how the patient actually collected themselves for limited. No one can actually do an NP swab on themselves, honestly. You can't get it back to the back of the NP area and collect a decent specimen. And what I find too, when I give people advice on how to collect these, it really comes down to getting that swab back to the back of the nasopharynx with enough contact, with rotation, probably for 8 to 10 seconds. Because if you don't collect it right, you're not going to get a good test result out of it. Next slide, please. Additionally, they kind of recommend that if you can perform a single RNA test and not repeat it if you have a low suspicion, but if you have a higher suspicion, to go ahead and repeat it. So the test itself isn't 100% sensitive. So if you have a high index of suspicion, I do repeat the test. Next slide, please. They made no recommendations regarding rapid testing. As Alan mentioned, these tests are sensitivity and specificity are not very good. And they suggest testing asymptomatic individuals if they've been exposed. So For example, if you're on a cruise ship or you're in a prison or in a nursing home and you have an indication you may have an outbreak, it makes sense to test these patients. And this is being recommended currently in our nursing home settings. So the most recent guidelines that have come out in the last week recommend that nursing homes test their residents every week and their employees every week to determine who is positive, to put them into the right isolation, and that way we don't expand it even broader, because that's the population that's having really poor outcomes. Next slide, please. Now, these two recommendations are dealing with asymptomatic patients with no contact and a low prevalence in the community and not testing those people. So again, if you're in Montana and you have a very low prevalence in that community, testing asymptomatic patients doesn't make sense. But if you're in an area that has high prevalence in the community and testing asymptomatic people, in order to kind of do that surveillance and be able to determine all those contact tracings in that population, it would make sense. Next slide, please. These two recommendations deal with immunocompromised patients. So if you have an immunocompromised patient being admitted to the hospital, they do recommend testing those patients. So say if they're on, they got a solid organ transplant and they're coming in, they may not develop the appropriate symptoms. So it may be worth your while to test that population. And patients who are going for any sort of immunosuppressive procedure, testing them at the time before you give them that immunosuppressive makes sense also. And you may defer giving them a solid organ transplant because of that positive status. So as we're ramping up our transplant program here at Reading, we're going to be testing all the solid organ transplant patients before they go to surgery. And if they're positive, we will defer their surgery until they recover. Next slide, please. Okay. And then this is dealing with perioperative patients. So they suggest for asymptomatic patients going for time-sensitive surgeries to test them. This is a challenge for a number of institutions. If you don't have enough capacity in your institution to do that testing within a short period of time, you may have to do it 2 to 3 days prior. And that's what we're recommending for our surgeons currently. I have limited capacity to do in-house testing with that 1 hour Cepheid test. So if they want to do the testing, not that I'm encouraging them to test everybody, but in certain populations of patients, for example, they might be going for a lung resection or any sort of ENT surgery. We may want to test them 2 days beforehand to get that result back before they go to surgery. And if they're positive, defer them. And we recommend, if we're doing this sort of test-based strategy, that we ask the patient to quarantine at home in the interim, so that way they're not exposed in the interim period of time. Realizing that, again, as Alan mentioned, if we test at certain intervals, we may actually pick up or miss patients because of the timing of our testing. Next slide, please. And these two are the last two. So this is for asymptomatic individuals who are going under an aerosolizing procedure. They recommend testing for that, and that makes sense just to make sure that you're not going to be contaminating your OR. What we're saying to some of our surgeons too, if you can't get the testing done, you should treat these people as though they have COVID, just to make sure you don't expose your OR staff. And then the second one here has to do with asymptomatic patients without a known exposure. They do recommend testing that population for the same indication. So that's kind of the guidelines for testing. Antibody testing is a whole other ball of wax, honestly. So what we do with this test, it's not clear to me. And the IDSA said, actually, they put out 2 statements regarding antibody testing. So realize that these tests came to market under an emergency use authorization, under an EUA, and they haven't been fully validated. And I get calls all the time regarding what to do with the tests, and is this actually protective? And we don't know at the time. So I'm cautioning us from sending out a whole lot of these tests and testing everybody under the sun because of the fact that they're not totally validated to the moment. I think we have better tests coming. I know Alan's bringing on the Diasorin test. It's an Italian company that's coming to market. And we're bringing on the Abbott Architect IgG test. I think those have really nice sensitivity and specificity, but some of these tests are being done out in the community at the present time that have a positive IgM and patients that had symptoms 2 months ago that may have been COVID. The timeline doesn't seem to line up for me. So when I have people that say, well, I had COVID a month ago, I had a positive nasal swab, am I immune? The answer is I don't know. And do I have to use appropriate PPE? And the answer is yes. So use the same precautions, don't assume that you're immune, and I just want people to be safe. Next slide, please. Okay.
That's it.
That's it. That's the end of my presentation then. So for this overall discussion, my challenges are to do with not having enough capacity for our in-house testing. We have the Cepheid platform that we're using currently. You can give a test result in an hour, but we order a lot of them and we only get a small allotment, and I can only really test a limited number of patients in-house. So the testing that I'm doing currently, I'm doing in order to treat patients with some of our investigational treatments for study protocols. And we're also doing that last test for the nursing home population that are waiting to go back to the nursing home that require that second negative test. Other than that, we're deferring, we're sending most of those out to a send out laboratory, and Mayo's our current laboratory. We also use Quest Diagnostics, and the turnaround time there is approximately 48 hours. Okay.
Well, thanks to both of you for those really informative presentations. That was terrific. We have 10 minutes, 8 minutes really, for some questions. I'm going to kick off the questions with this one. Everything we read about talks about limitations in capacity. Dr. Powell, you talked about the problem of pending results, and obviously the time lag between when a specimen is collected and what's submitted to the lab and when you get the test result. And I guess I'm interested in hearing from both of you, Dr. Powell and Dr. Evangelista. What's the problem? What's the supply issue? What do we need to do to accelerate the pace of testing so that we have more real-time results? And how do we expand capacity in the way that we keep reading about that we need to really give us visibility on this epidemic?
I could give it a first shot. I know that the manufacturers are aware of this, and they're increasing their capacity to produce tests. There's a long delay in when they initially started to produce accurate tests. There was a couple of month delay. Cepheid is building an entire new production line to increase capacity, probably in July. I know BioFire and Diasorin and some of the other companies are increasing production, but right now, most of the companies that are producing test kits are producing them at their maximum level. And the only way they can produce more is to build a new facility. So it's their own capital that they're using for expanding that. The demand is incredible for testing. If we're trying to test people before they go back to work, we're nowhere close. I know the Harvard study a few weeks ago we're talking about, we're doing hundreds of thousands of tests a day. We should be doing 2 to 3 million, maybe more tests per day. There's no way we can meet that capacity. Even with the expansion of the individual companies, there's, as you see from the slides that I presented, there's about a dozen maybe major companies that are producing PCR tests, and their capacities are limited. What do you think, Debra?
It's the question I ask every day, and I call the lab and I call our supply chain vice president. I say, can you get me more? Because again, the demand is so great, and as our politicians are saying we have plenty of testing, we don't. We need more testing, and we can't do a better job until we get that testing capacity expanded.
The other issue with that is that the testing has to be within a reasonable turnaround time too, within a 1 or 2 hour turnaround time. We send out to reference labs. We divide our tests into what we send to the State Department of Health, what we send to a private laboratory, and what we can do in-house. And I wish we could do more in-house, and that only depends upon the allocations. Every company that I speak to, we were forced to do allocations because there's such a demand around the country. And if you have a very good test, and I'll use Cepheid as an example, it's a reasonably good test. It's 45 minutes, but even with their expansion of production in California, the allocation is going to be the same in the foreseeable future. Nothing's going to happen in July, August, or September as far as, from what I can see, increased number of tests coming to the individual hospitals because everybody wants it. So what hospitals are doing is they have several platforms. We have 2 major platforms. We're going to 3, we're probably going to 4, different manufacturers just to keep up with demand.
Mm-hmm. Yeah, totally agree.
Is the issue test collection materials? Is it the reagents in your laboratory? Is it the entire supply chain that needs to be somehow expanded?
Certainly test collection materials has been a real issue across the United States. A lack of swabs, a lack of viral transport media. Fortunately, now we have some leniency on that the FDA and other validation studies have been using sterile saline, phosphate buffered saline as viable transport. So that may help in the long run, but still getting the swabs is always a challenge. You can't get flock swabs. There's only two major manufacturers, and I didn't realize this until COVID started, but Puritan and Copan are the major manufacturers of flock swabs. That's the best swab that you could possibly use. And there's only two companies in the world that manufacture that. They're expanding, they're building new facilities, but that takes time. When you put a new building together and then robotics and the whole plant, it's going to take at least 2 months. So hopefully that picture will improve in the future. But right now, some of my colleagues, even on ClinMicroNet, were talking about 3D printers for making swabs. Some of them worked, a lot of them didn't work. So they have to be very creative at this time. There are some new tests coming out for saliva, and so that that's a good possibility as well. If you're able to collect saliva from patients, it's not going to be as accurate as nasopharyngeal or a mid-turbinate nasal, but that's another option to look at.
So much of the public health control and management of this pandemic in a pre-vaccine phase or era depends on our ability to identify cases. And I guess, we talk a lot about Dr. Powell, you talked about the current recommendations for nursing homes, and just in Pennsylvania, but really many states are, have mirror those recommendations. Certainly New Jersey has. Do we have enough testing to even do what's recommended now? Do we have enough capacity?
It's a challenge, and actually those nursing homes have reached out to us because do they have enough PPE to collect this? Do they have enough viral transports? And where are they going to send those specimens? So again, we have relationships with our reference laboratories, but up to a certain volume. And once we expand over that volume, we have to find additional reference laboratories to send those specimens to. And that's why we're expanding out between 1 to 2 to 3 reference laboratories. And that's just for our local nursing homes. And some of these are state nursing homes. So you would think that the state would support them and maybe the Department of Health would take those tests, which they have not, they don't have the capacity for it. So the community is trying to support the nursing homes, getting the specimens collected and working through, like our urgent care centers, actually some of their people are going to be going out to collect specimens on these nursing homes once a week in order to do it right.
So what are other countries doing differently? We read about South Korea, hundreds of thousands of tests a week. What are they doing differently? Do they just have more domestic capacity?
They are using, a lot of the screening tests are antigen screening tests, which aren't very accurate. A lot of the antibody tests are are picking up human coronavirus. I just read a paper a few days ago from Japan, where they were saying 3.5% of the people, I'm trying to remember the city, and I'm not sure if it was Kobe or Osaka, but it's probably more like 1.5% have a prevalence because they're picking up a lot of background viral antibody by using inaccurate tests. I guess when you have nothing, you use something that's not 99% specific, maybe it's only 90%, but then you have to look at, what's happening in the community and is it a high or a low prevalence area. So the data is, whenever you look at data, you have to look at the limitations of what tests are being used. And you can mass produce a lot of things. We're getting flooded, I'm sure Dr. Powell is too, with new tests every day. I'm reaching out by manufacturers. My first question is, have you gone to the FDA? Well, no, we haven't. We're just selling the test on the market. Well, then I'm not interested because I have my suspicions that it's until I see data that shows me the test is reasonably accurate. We wouldn't want to flood our area with inaccurate tests. Primarily, a lot of these rapid tests are going to primary care physician offices. that's a concern also, because if you run a test and it's negative, how confident are you in that negative? Well, at least the FDA says if you're not that confident, put a statement in your package insert, your information, that says you really need to follow up a negative with a molecular test. And then, well, why did I buy the test in the first place if I have to follow up every negative with a molecular test? So it's a very interesting time with rapid flooding of the market. Everybody knows they can make money for some of these tests, and you're getting tests that may not be as accurate as you think. And even when they first come out, when your manufacturer puts out their IFU, their information for use packet, the numbers look fairly good, but you have to wait for a third party to do an evaluation or to use a standardized limit of detection. Some of this information, it's very difficult to find what's the limit of detection. Then you look at the method. How do they even come to that conclusion? Well, you have to do a tissue infecting dose, 50% of your cell culture. How did you do the cell culture? What cell line did you use? And so there's those variables too. So what I'm looking at are standardized methods that can be compared across the board, and looking for literature that says, all right, we evaluated 4 tests side by side using the same standard. What's the limit of detection on these tests? So the numbers keep changing, and more sense, it's more of a range, but it's an interesting time that we live in, because normally in the past, when a test came to market, you did your own verification because it was already vetted by the FDA thoroughly. Now, because of the urgency to get tests in the market, and especially point of care tests, we're looking at what the limitations are. And and also the instrumentation, we didn't talk about that, but I've contacted companies to say, I'm interested in your PCR assay. How soon can I buy an instrument or get an instrument? Oh, well, we're only producing 8 a week or 10 a week. It's going to be 3 months. There's a 3-month waiting list on the instrument. The Abbott Alere test, contacting Abbott, that's just as an example, but if you don't have an Alere I instrument, which is now the ID Now test, you may have a wait of a month or so just to get the instrument to read the rapid test. So there's factors involved in how quickly can you produce instruments? How quickly can you get reagents? If I buy the instrument, are you going to be able to support me in the next 2 months with a good supply chain? Quite often the answer is no. We're going to have the same allocation. So why would I buy another instrument if I'm not going to have reagents to test for it? So it's a really interesting time for trying to obtain testing. And it's going to slow down. We're seeing the curve slow down. What I like to look at are hospital admissions, because that's a better indication, because the number of positives is an artifact of how many people we're testing. But if we look at hospital admissions of COVID-19, we're seeing that go down in Pennsylvania, which reflects what Dr. Powell was saying too. We peaked in the early to mid part of April. We're seeing a slowdown through the end of April through May. We know that coronaviruses don't like warm weather, don't like higher humidity. Certainly outbreaks in clusters will occur throughout the summer if people are enclosed in a closed space and they're not using a reasonable amount of social distancing. So that's a potential. But overall, things should slow down June, July, August, September. When we look at our own data, we don't see human coronaviruses circulating, or at least as far as admissions to St. Christopher's Hospital in June, July, August, September. We start to see them again mid-October, end of October. So that's another thing to look at. Look at the Southern Hemisphere, what's happening down there in their fall and winter, and they're seeing an increase in cases there. So just like the flu season, we may see an increase here as well. So stay tuned. It changes every day. It changes every week. And hopefully, I'm anxious to have consistently warmer weather. If we look back, I'm rambling on here, but if we look back at April was a colder month that we normally have. I was thinking that, this will go away by the end of April. Well, no way, because if you have colder, drier weather, what happens inside where most people are? You're using indoor heating, you're drying the air. and coronaviruses will continue to spread that way. Obviously, social distancing is number one. Have to wear a mask to protect yourself. You don't know who's asymptomatic. And we now know that asymptomatic individuals may spread as much virus as somebody that has symptoms. So that's a very difficult concept to grasp. And from that respect, we spread a lot of virus before symptoms, just like flu. But it's different than SARS. SARS, you have your viral load peaking at 2 or 3 days after symptoms start. So every respiratory virus has its own pattern. And we're seeing that SARS-CoV-2 has its own unique pattern for spreading, which is in favor of the virus and very much against people that don't know that they're spreading it and then don't know that and 80% are either going to be asymptomatic or mild. So that's a really interesting concept for this particular virus.
Well, we're a few minutes over time. I want to thank both of you, Dr. Powell and Dr. Evangelista, really two terrific guests for great presentations. And I'm hopeful that in the coming months, before we think about our fall respiratory virus season, hopefully there'll be some more capacity in this area. So again, thanks to both of you for your time this afternoon, and thanks to the audience for joining us. And be well, stay safe, everyone.
Okay, thank you.
Thank you very much.
Thanks for having us. Okay. Bye.